this week on the BackTable podcast.
You talked about how you want to restore the sagittal balance in these patients. This is an argument for early treatment of kyphoplasty, as opposed to getting to it 3 months later when they have when they're compressed down and there's no way you're ever going to fix their kyphosis. I've had patients who, once they get that compressed, they start having what's called postural fatigue syndrome, which is where there's that focal kyphosis in their spine. All the muscles of their spine just get worn out from constantly trying to pull themselves into the correct alignment. So they wind up with pain right there at that level that relieves when you do median branch blocks, because it has to do with the facet joints there, because you're putting atypical force on those facet joints due to the kyphosis, and it has to do with the multifidus muscle at those areas just getting worn out by trying to hold things up.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com.
This is part 2 of our conversation with Dr. Glade Roper. If you haven't heard part 1, we suggest going back and listening to that episode before continuing on here.
So we're going to pivot a little bit. We're going to start pivoting into talking about kyphoplasty tips and tricks, of which you become well known for sharing these on LinkedIn and X, and always enjoy seeing your cases, which you have a few to share. Let's move into that direction by talking about the kyphoplasty portion of the bone tumor ablation. A little different than run-of-the-mill osteoporotic fracture. You can see all kinds of weird fill patterns and stuff like that. Tell us about things you've learned about this.
Well, one is, if the fill looks like a balloon animal, that's not atypical after you've done an ablation. That's what somebody used to describe it as balloon animals. And I said, oh my gosh, that's what it is. Because it just forms these weird shapes. Don't be alarmed. That's just the way it looks after you do an ablation. If there is a fracture line, you still want to make sure you fill it. And you're going to know that from your pre-procedure imaging. And there's a couple of ways that you can fill it if the cement is not going in that direction the way that you would like it to. First of all, you've got about 10 minutes of working time on your cement, or however long you've got of working time, so don't panic. There'll be plenty of time for that later. So the first thing that I will do is just put a beveled tip trocar in and angle the needle to go the direction that I want the cement to go. As in, if I'm trying to get the cement to the superior end plate and my needle is sitting in the middle of the vertebral body and the cement is just forming a balloon animal there in the middle of the vertebral body, what I'll do is pull it back to the posterior aspect of the vertebral body. So I'm not coming out into the pedicle. I'm still in the vertebral body. I'll use the bevel tip to angle, and then I will crank that thing and try and angle it upward to get that needle to pound into the fracture line. If I can get that needle into the fracture line, then I just put my cement filler in there and fire away. And almost always that winds up fixing the issue.
Very satisfying when you finally get that fracture fill after it's been evading you for a while.
Yes, it's very satisfying. It requires no additional equipment. It just requires that you be thinking about it and notice in a timely fashion that the cement isn't going where you want it to go, and figure out where you want it to go and figure out how to get your needle there. Like I say, just putting a bevel tip in and angling it around tends to fix probably 50-60% of the problems.
I agree.
For those others that aren't cooperating, there are other tools you can use. This is actually something that you use before you ever get to that point, which is when you're inflating the balloon and you notice that the balloon is only filling the inferior aspect of the vertebral body, and you're trying to get to a fracture line in the superior aspect. Then you have an inkling that, okay, I'm going to put cement in here and it's just going to go where the balloon went and it's not going to get up where I want it to go. So there's a couple of tools you can use in that case. One is you can redirect right then and there before you've even mixed the cement and see if you can get into the superior aspect of the vertebral body with your trocar, and then you've got time. You don't have the pressure of tick-tock, the cement is hardening on you. But anyway, if you notice that, you can try and get in there with your trocar technique right off the bat. If you're not, if you decide that you'd like to do something else, you can get out the curette, which is kind of a fun little tool. It goes in, and then the tip of it will hook up at 90 degrees, and it's made out of a fairly stiff metal, and you can take that and just twist it around and grind and break up the bone in the area that you want it to go into. It is not uncommon that I will have my reps bring one of those in and do that.
Curette is a really highly underutilized tool. I found it's been very helpful in a handful of cases, and it's something I think there's a lot of people who probably never used one. I think it's a great thing to have in your tool belt.
Yeah, I hadn't used one in probably 2 years, and I had a case once and said, you know what, do you have a curette? And they went and, blew the dust off the box and brought it in, and I used it and said, ooh, hey, that works really well. And ever since, the reps know to keep 1 or 2 in the box just in case we need to use it. The other thing that I will use is Medtronic makes a curved introducer it's called the Kyphon V. It is a straight 10-gauge catheter, and then it's got a curved nitinol introducer that goes through it. So you can use that introducer, you can use that curve without the introducer and just put it down through a regular cannula, and that enables you to put a curve and send that whichever direction you want to send it to fill the vertebral body with cement. That's another tool that I've used quite a bit. If things are not going the direction that I want them to go, and I'm not able to get the trocar to move it up there the way I need to, often that's the next tool I will reach for, is that curved introducer. And you just tap it down under X-ray, and you can watch it flip up into the fracture line. You pull out the little plastic thing on the inside that, it's got a little plastic thing that fills it. And then you can just attach your cement to that and inject directly through it. After injecting directly through it, you can detach the cement, pull it back, reposition, and pound it forward again. That will usually work. If you're not careful, you can stick some piece of hard bone in the tip of it and it won't work anymore. And then what you have to do is use a metal stylet that they include with it that you cram down there. And that is when you get to make your upper body time at the gym work. And, it shoves all the cement out. So you want to do that under fluoro to make sure that you are putting the cement where you want to put it. But you can clear it with that, I don't know, it's just a metal stick that you push down it and pushes everything out.
It's just some sort of metal stylet.
Yeah.
That goes in there. Yeah. I mean, really great points that you brought up. And this is something, my thinking on this has evolved a lot over the last few years based on kind of how I've seen the cases done, is that a lot of people will just kind of fill and see what happens, and they'll say, okay, that's good, put in a few cc's and say it's good. As you have said, I'm going to let you finish the sentence here. Saying you have too much cement in a vertebral body is like saying...
It's like saying blank. You've got too much money in your bank account.
I agree completely. And I would say, when I started my new job, scrubbing a couple cases with my partners, and I was injecting some cement, and my partner, who's a very IR with 20 years of experience, does a fair bit of kyphoplasty. He's like, okay, yeah, you pushed it further than I usually would have. And it was fun. Nothing even extravasated or anything. I think a lot of people were just like, that's good. That's good. But the more that you can do without causing untoward issues, and you got to be watch like a hawk for the basivertebral plexus, anterior extravasation, any kind of venous extravasation, just keep an eye on it. But the more that you can get in, the better, and for preventing a secondary fracture. And that happens a lot in the osteoporotic patients, but also in the oncologic patients too. And I feel like, you may only have, hopefully you follow up on these patients, but you may only have one shot to kind of get it right. So that's kind of how I treat each kyphoplasty, is try to optimize it as much as you can. And we have some data showing that the cement volume is really the single modifiable factor of the procedure that increases the success over time.
On that note, I want to add something with respect to radiation therapy. I mean, you said this may be the only shot you have at it. Doing a kyphoplasty in a bone that has been irradiated is an exercise in frustration. I'll also say this. The order of operations, if you have a patient who's got painful bone mets, should be RFA and kyphoplasty followed by radiation, not the other way around. One of the reasons is the radiation therapists have to do their pre-planning CT, and their pre-planning CT takes into account the density of everything, and they draw their little lines and figure out how they're going to shape their beam to appropriately irradiate that part of the body. If you throw a bunch of cement in there after they've done that planning, it screws everything up. So it's important to put your cement in, then plan, then irradiate.
Mm-hmm. Great point. And it reminded me of something I was thinking about earlier when talking to your radiation oncology colleagues. Their modern radiation techniques are incredible, really good, and really do quite well with pain relief as well. But one of the things that when we kind of compare the strategies that we use is XRT comes with it a risk of potential skeletal adverse events down the line. So basically pathologic fracture down the line. So that's why I really like this complementary approach of RFA and kyphoplasty first. And then your rad-onc is protected, your patient is protected from that happening, basically.
Yeah.
And as you said, it can be, I personally haven't had the experience, but I've heard from many people who have trying to do an RFA or even just a standard kyphoplasty in irradiated bone, even a couple weeks after. It's like trying to drill into concrete, and it's terrible.
It is no fun.
And it's tricky because modern systems of care are so complex and multifaceted. And in a perfect world, I think that would be the great and the correct order of operations, but doesn't always go that way. And so I'm wondering if this is your experience too, if you can get them in after radiotherapy, but before it's been too long, you usually still have a good shot at having a non-aggravating RFA.
Yes, that is true. I still think that we do the patient the most amount of good by treating them, kyphoplastying them, and then having the radiation therapist go to town, or radiation oncologist go to town and do whatever they're going to do. Mostly because, as you say, this is the best shot you're going to have at it, and you want to give yourself the best opportunity to be successful. If you're going to do it, make it as easy as you possibly can. Why make it hard for yourself?
And for the patient, for that matter.
Yeah.
If I've experienced anything, the patients do not typically like it. And our patients are usually under moderate sedation. When you really start to have to give them the wham on that mallet, it's not usually taken well.
No, nobody enjoys that part. I don't enjoy it. The nurses don't enjoy it. The patient doesn't enjoy it. Nobody enjoys the feeling of, if I'm breaking a sweat pounding that in, then everybody in the room is uncomfortable.
Have you used any of the power drill methods?
Yes, once. It was one of these patients who I attempted to do a kyphoplasty on, or an RFA and kyphoplasty. She had a painful T5 metastatic lesion. And
it's a tricky one.
It was a tricky one. So I brought her in to do a RFA and kyphoplasty, and bam, 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 nothing. So we had to send her out and bring her back, and I had to go down to the operating room and get a striker drill.
Okay, the real big boy toy.
And drill into this vertebral body so I could do the RFA.
Awesome. And sometimes you have to. And the reason I bring this up is I was just doing a bone marrow biopsy the other day, and we had a rep in who was kind of showing me just all the different pieces of the kit. And Dana Dunleavy has also talked about some ways he's kind of used multimodal, if you will, parts from the bone marrow biopsy, hand drill, and bringing that over, and you can get access with that much easier in this type of bone. K-wire, and then take that out and exchange that for your standard cannula. That's one way of doing it as well without having to get the big time drill.
And that's exactly what I did with the striker. I got my drill in, I was able to drill down, then I put in a K-wire and exchanged it for the cannula for the RFA device.
Yeah, I bet you wish you had done that from the beginning in that case.
I do. I do. I wish I had done that from the very start.
So do you think if you have a patient who say has been sent to you, it's been a few weeks since their radiation, or you're looking at it, it looks like some pretty hard looking bone in there, you think you go ahead and grab that drill?
Yeah, that's when I think about it. I think hard about grabbing the drill right off the bat so that I don't make everybody uncomfortable.
Right, right.
Was it fun? Absolutely. that was a very fun day to be doing that case.
Yeah.
And everybody in the cath lab, their eyes were about this big. Like, what are you doing? I said, no, just trust me.
Just drilling. Yeah, exactly. So we've talked about a lot of great tips, and one thing I want to know is your process of washing cement. What are the things that you look for when trying to stay safe, but also trying to maximize the amount of cement you can put in?
That is a great question, and this is one of the art of medicine type of things. The device that I use has a little hand pump so that I can stand way back and watch while it's going in so I don't irradiate myself as much. But what I will do is just pump very lightly and quick, very short, very quick pumps as it's going in. And the main place where I don't want it to go is out the back, because that's the dangerous spot. That's the danger zone. Having it go out through the back of the vertebral body is bad news for everybody. So you want to watch for the basovertebral flexus filling with cement. If that fills with cement, stop, disconnect the cement from the catheter, from the cannula. That is the only way to absolutely relieve all the pressure on it, to make sure that you're not maintaining a pressurized system. And then wait. Take your time, let that cement harden, because it's always going to follow the course of least resistance. The path of least resistance is where the cement's going to go. So you just want to make sure that it forms a different path of least resistance than the one that it's going on that you don't like. And the way you do that is either wait for the cement to harden or reposition. And whichever one you choose to do, that, as long as you do it within the working time of your cement, you have not created any issues for anyone. Especially if you're confident that you've gotten the right spot, then just sit and wait. If you're not feeling the fracture line, move until you are going to fill the fracture line and then start injecting. And just make sure that it's not going too far backward. If it's going too far backward, pause, take a look, wait and see what's going on, flip around and see what you're doing, see where everything is going. I have not had good luck with the eggshell technique.
Yeah, tell us a little bit about that. I've been curious about it. I haven't used it myself.
The eggshell technique is ostensibly you've created your cavity with your balloon. You put a little bit of cement in, then you stick your balloon back in, blow it up, and let the cement harden around it so that you have created a safe fill zone for you to fill with cement. The problem with that is a little tricky because you don't want to glue the balloon in the patient, and raise your hand if you've done that. And you don't want to, if you pull it out too soon, then the cement just kind of flops around and doesn't do anything. If you pull it out too late, you glue the balloon in the patient and you have to, tug it out and pull that out. And almost always the balloon pops.
Yeah, that's almost a foregone conclusion in that. So,
because the cement heats up and just it has a chemical reaction with the balloon and it pops. So now you've got contrast all over the place. I've tried it and never had good luck with it. I think I may just not have been patient enough to do it and let it work, but
it sounds like a tricky technique. It sounds like one of these things that very useful in theory, but as the saying goes, in theory, there's no difference between theory and practice. In practice, there is. And that's one of the things. And I found that I think that's a cool idea, but I found that just being willing to redirect your cannula goes a long way towards getting the cement fill that you need to do without causing any issues. And as you said, when it comes to posterior, it's really that basivertebral plexus, kind of that little reverse flame-shaped thing that you see on the MRI if you actually look at that part, and also lines up with the basivertebral nerve, which talked about at length. That's the primary egress for the cement posteriorly. So it seems this notion that some people say, oh, cement's started to go posterior, abort, just call it up, yank the cannulas out.
Wave off, yank everything out. No. Don't do that.
Yeah, no. Don't do that. And so going posterior, I don't know where this myth started, but it is a myth. It's not true. That if you start to fill the posterior third, you have to just stop and whatever. That's not true. So you have to look for that basivertebral plexus filling. And what I really like about that, when I see that, I'm like, awesome. Because I know that wait for a minute, let that harden up, and then you're pretty well protected from it going out into the ventroepidural space. You still got to keep an eye on it, but I like when, you've plugged that main egress and then you're kind of like, okay, sweet.
With the caveat that if they have a fracture line going through the posterior wall, then they've got another place of egress that you need to keep your eye on.
Exactly. So you really have to, I would say just constantly be monitoring, it's like when you're driving, you're focusing on different things and your eyes go between. And so you need to monitor the anterior cortex and the posterior cortex and look for those telltale signs. And the other thing is when you actually start to get a fill in the ventroepidural space. And this is something that's happened to all of us. And I will say probably 99.9% of the time it's asymptomatic and it's not of clinical concern. And personally, when I dictate my reports on a kyphoplasty, or if I'm looking at an imaging study on a follow-up, I am brutally objective describing all these things. And I think it's important to know that, there is the possibility of that happening, of getting some cement in the epidural space. If that happens, same as if you're filling the plexus, just take all the pressure off, don't inject anymore. The cases that I've seen that have been really bad is when people didn't recognize it and they just kept pumping it. And then you end up with severe stenosis, and that's a major issue. So one thing I would say is always know the patient's degree of stenosis at the fracture levels you're doing. If they have pre-existing stenosis, just be aware of it, and don't go adding to it. But a patient who has mild or no real stenosis, you don't need to worry about if a little bit of cement goes into the ventroepidural space. Almost always that's going to be asymptomatic. That doesn't mean do it with impunity. That's not what I'm saying at all. But sometimes you will start to see that little lenticular shape. You'll just start to see it fill mostly along the contour of the posterior cortex and just stop. The problem is when it starts to bulge out posteriorly. And that's when you get into issues there.
On that note of bulging out posterior, there's some of these fractures where the bone itself is bulging out posteriorly. When you have a compression fracture and you'll get a little bit of retropulsion of the posterior wall. One of the things I found that's nice is when you go in and expand that up, a lot of times it sucks back in, which is a helpful thing to do for the patient. You've relieved a lot of their stenosis.
That's a great point. And that's something I've had this even come from ortho spine surgeons who say, oh, well, you don't want to put a balloon in there because it'll shoot that fragment out. It's like, man, I took a couple of semesters of physics, and I don't think the free body diagrams add up in that favor. And due to ligamentotaxis, as we've seen, usually when you inflate the balloon or implant or something like that, it will typically suck that fragment back in, as you say. And so, and that's really nice because I think that the more you can get the patient back to their normal sagittal balance, I think is good, because these patients may live for a long, long time afterwards. And so I want their biomechanics to kind of be as good as I can possibly make them. And so point really well taken about that little, I've taken to, honestly, I don't have much fondness for the term retropulsion because I think it gets thrown around. I use that in the context of like a complete burst fracture, and there's fragments actually going back. And I think what you're talking about is that little, usually superior end plate bowing that you get posteriorly. And so I've taken to calling that, mild bowing of the posterior aspect of the superior end plate or something like that, because people get really worked up when they hear retropulsion. And, we're kind of talking about associations, like the association of cement going posteriorly. Oh, you gotta stop. The association of retropulsion is almost taken as a surrogate for neurologic compromise, which is, it's not. But people get worked up about certain words, and so that's just something I've taken to more recently using a little bit different vernacular to describe.
Something else on those same lines. You talked about how you want to restore the sagittal balance in these patients. This is an argument for early treatment of kyphoplasty, as opposed to getting to it 3 months later when they have when they're compressed down and there's no way you're ever going to fix their kyphosis. I've had patients who, once they get that compressed, they start having what's called postural fatigue syndrome, which is where there's that focal kyphosis in their spine, and all the muscles of their spine just get worn out from constantly trying to pull themselves into the correct alignment. So they wind up with pain right there at that level that relieves when you do median branch blocks, because it has to do with the facet joints there, because you're putting atypical force on those facet joints due to the kyphosis, and it has to do with the multifidus muscle at those areas just getting worn out by trying to hold things up.
Yeah, such a good point. And I would say any thoracic fracture patient who you have come back in, this is something you have to consider, is this postural fatigue. Sometimes you have them come back in 2 weeks later, knocked it out of the park, kyphoplasty, BTA, whatever, couldn't have been more perfect. They said, I got a little bit of pain right there. And usually you find, if you kind of palpate them, posterolaterally, the area of their facets, that's usually where they're tender. And it can be a frustrating problem. As you said, medial branch blocks can help, and rhizotomy, even if it's needed. For a lot of these patients, tincture of thyme tends to do the trick. But as you say, they seem to be more predisposed towards that if their fracture is such that their sagittal alignment is already kind of mucked up. And in certain situations, try as we might, you can't always get that. You usually can't get that back to square one.
No, if it's been more than a couple of days, I usually find that I'm not going to get them back to their full alignment. I mean, and it doesn't matter what kind of vertebral body stent or other devices you're throwing in there, you're not going to get them back to normal if it's been months, just because of the healing processes that have taken place. Which is why insurance companies who say, no, you have to have done 6 weeks of physical therapy before you can have this fracture repaired, makes me want to slap somebody. And I've gotten full snark mode and said, oh, really? What physical therapy would you recommend to help this fracture heal? And they obviously can't give me an answer when I'm doing a peer-to-peer, because, there is no answer. The treatment for a broken bone is fix it. It's not sit and make them lift weights.
Yeah, exactly. Sit and make them lift weights and see if it'll heal on its own. And then if it gets worse, do something about it. This dichotomy of non-operative treatment versus, and I've seen patients who have progressed to, something close to a plana. And then apparently in that situation, it was, not going to do anything. And the patient collapsed. And then the course of action taken there was to do a 5-level spanning pedicle screw construct. And so just this dichotomy of doing nothing versus something pretty invasive and I would say unnecessary. I just don't like that. And so I agree with you. Treating early is just the best thing. You always get the best outcomes that way. And the patient is suffering less. So for me, it's a no-brainer. I really struggle with this, especially from the insurance end.
Yeah, I mean, it just drives me batty when I hear, oh yeah, this patient has insufficiency fractures. And the treatment that we prescribe for that, practicing medicine without a license, is physical therapy.
Show me the data that supports that. And you can't, because it does not exist. It does not exist.
And it flies in the face of all common sense as well. So
it does.
Sorry,
absolutely.
Let me get off my high horse here and stop bad-mouthing insurance companies.
But point well taken about cementing as soon as possible. You will have the best outcomes, both clinically and honestly cosmetically. We like to see a nice fill. We like to see a nice in-plate to in-plate, pedicle to pedicle, a little bit of height restoration, maybe some balloon animals. You have to accept that. But sometimes when you're getting these patients, weeks, maybe even months after they're fractured, and as you alluded to, it can be difficult because you start to have almost like this partial bone healing. It's just oligotrophic non-union. And so sometimes you'll have some sclerosis in there, and it's way harder to inflate your balloon or whatever you're trying to do, even just trying to get access sometimes. And I've had patients who have had fractures months and months and months ago, and you can tell, it tried to heal, but you still have this air-filled cleft. And I think that's something that we've become really attuned to, is seeing the actual black air in the CT filling that cleft. That means that's a mobile fracture. And so when the patient lays down or stands up, that thing is basically flapping back and forth. And then the corollary often being the fluid-filled cleft on MRI. We've harped on this. You got to fill the fracture line. But I would say one thing I've noticed is that some reports will just say, chronic T12 compression fracture or whatever. And it's looked like that since the last CT. There's some sclerosis, but you're ignoring this huge non-union gap that's in there. And so I think that's something that's really pertinent to recognize, and to our radiology colleagues from our own specialty, I think that's something that we need to be quite a bit more vigilant about describing.
Absolutely. And that's why I want to look at all the studies myself. I have a hard time trusting radiologists who aren't me. So I tend to want to look at the pictures myself. I want to make sure that I know exactly what's going on.
Yeah. And I would say that that's a great practice for everybody who's treating these. I've heard of people who are, treating compression fractures or even bone tumors, just kind of looking at the MRI report. And I'll say, this is just kind of a, natural thing at this point for surgeons and for interventionalists. You got to look at your own imaging. Even if you're not, usually you're not the one who dictated it. Sometimes you are. I found that that's been really helpful the times when, for example, I had a patient who I had to treat, a very complicated patient, and required a second round of treatment. And I got imaging study on her in between, and I dictated that myself. And because I knew everything that had happened with the patient, I knew exactly what we had treated before I knew the morphology of the fractures, I was able to describe that. Basically, that if one of my partners had to treat that patient subsequently, they could look at the report and say, okay, yeah, there's kind of the blueprint right there. And so that's kind of the approach that I try to take. But I agree with you completely. I need to see this study myself. And I try to, personally, my dictation style is to imagine each patient as my own patient. What would be kind of the treatment roadmap, or what are the salient findings to do? I'm getting a little bit on my radiology soapbox here about that, but I think recognizing these elements of fracture morphology is really important. Not something that, I didn't learn that in residency much. I learned these various tips and tricks from people like you and Dr. Beal, Ed Yoon, and other people. You just kind of pick up on them, and to my knowledge, it's not something that's incorporated into residency curriculum.
No, it's not. And I will say that doing these procedures has made me a better reader of spine MRI.
100%. 100%. I agree. And it's made me more facile too. You catch things. For example, I read a lot of spine x-rays now too. And these are notorious for just things get missed, and it's easy to say, just miss the T12 compression fracture that's there. And so I pick up probably every day, at least a couple of compression fractures on there. And am I going to do something just based on an x-ray? No, usually not, but it's more of a screening test, and you kind of push them forward. So the more you treat these, the more you see the corollaries with MRI, and then you start to see corollaries even with the x-ray, because we're working under x-ray, we're working under fluoro, and everything translates 1-to-1 basically.
Yeah. Same thing has happened to me with MRI of the pelvis. Now I look at MRI of the pelvis, and I'm a lot better at looking at the SI joints. I'm a lot better at looking at, the ligaments back there, looking at everything. Just the fact that I'm treating a lot of this stuff makes me know what to look for. And it 100% has made me a better radiologist.
I agree completely. So, Glade, before we wrap up, we've talked about so many great tips and tricks. We've talked about practice building for bone tumor ablation, and just a lot of great pearls that our listeners can implement into their practices. And we're going to discuss a few cases that'll be available audio visually on the YouTubes and whatever other outlets. So once we wrap up this formal part of the podcast, we'll get into that. Any closing thoughts you'd like to share on anything?
The most important thing that I do in any given day is, everybody says their favorite procedure is turning on the car to come home at the end of the day. And that's my favorite procedure. And the interactions that I have with my kids and my wife, that's life. What I do for work is fun and exciting, and I really enjoy it, but that's not the main part of life. The main part of life needs to be the relationships that we have with our loved ones. There's a little bit of a tension there always when we're doing this, because our job can suck up every ounce of time that you could possibly give to it. I mean, if I allowed it to, I'm sure I could work 16 hours a day, sleep the other 8, and not notice anything else. But the best parts of my life are the parts that involve my kids and my wife. And it is so important to make that a priority. At some point, you need to, put down the dictaphone, shut off the pager, and go and be dad or be husband.
Really well said, and couldn't agree with you anymore. And I think that's what you have to have, that sense of centeredness, because otherwise, speaking to a patient who's grappling with cancer and this vulnerabilities we talked about earlier, I don't feel that you can fully connect and fully address their concerns if you yourself are not centered. And I won't get too much on my soapbox there, but thank you for sharing that. Couldn't agree more. And it's been great having you back on the show.
Dr. Glockenflecken does his impersonations of various specialties, and the one that comes to mind is the neurosurgeon, I love
that skit.
During the neurosurgery interview, he says, "Do you have a wife and kids? Do you have a wife for now? Do you have kids? I don't know. You'd have to ask my wife." So, you can't do that. You can't. I mean, if you cut yourself, you have to bleed. You can't spark. You have to be a human being.
Yeah, I agree. I agree completely, wholeheartedly, and I think that's what makes it fun, like you said. Because otherwise, yeah, you could work 16 hours a day, and then you're just grinding away. And where's the fun in that? And so, and it's a constant battle of balance. I think balance, personally, I think it's a myth. Is this idea you can be a tightrope walker just going perfectly. What you notice about those tightrope walkers is they're always kind of wobbling to one side or the other and constantly making corrections. So the idea of perfect balance is, I don't think it exists. But as you say, by focusing on these parts of our lives, you really can be the best part of yourself. Sorry to get a little profound, but I really appreciate you shared that.
I mean, again, not to get too personal, but one of my daughters were in a car wreck a couple months ago, and one of them got a concussion in the car wreck and still has not been back to school. So that has been really kind of wearing on us. We're trying to make sure that she's recovering. And one of the things that has stood out is how happy she's been. She's been just in a really good mood. And we said, what gives? And she said, I just have a lot better perspective now. I mean, a lot of the things that I was getting angry about were not that important. Now I have a lot better perspective.
Perspective's everything. Well, it sounds like your daughter is wise beyond her years.
She
is.
And
I'm glad I'm glad she is doing well at this point.
Well, she's recovering.
It's a scary experience.
Slow. It's just concussions take a long time to get better.
Concussions suck.
Yes.
Yeah, seriously suck. Wow. I'm sorry to hear that. I'm glad she's on the up and up, though. Well, awesome. Well, Glade, thanks for joining. This has been a pleasure, as always. And to our listeners, thanks for tuning in. Make sure to watch our case discussion that we are about to go into. And otherwise, we will catch you next time on the BackTable MSK podcast. Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.